guys, and welcome to How to Gastro. In today's video, we'll be talking about Hirschsprung's disease, and this is a common pathology which is mostly found in the pediatric surgery department of hospitals all around the world. So let's learn today a little bit more about this disease and see what it's all about. So to begin, let's start with a definition. So what is Hirschsprung's disease? Hirschsprung's disease is a disorder of development that affects approximately 1 in every 5,400 to 7,200 newborns annually. The disease is characterized by the absence of ganglia in the distal colon of the patient, which ultimately results in a functional bowel obstruction for the child. So from the definition of the disease, we get that it is a developmental disorder, so it usually will affect newborns because a developmental disorder means that there's something wrong in the development of the fetus, and when the baby is born, we are able to appreciate the signs and symptoms that the baby presents with. We also get that it occurs in approximately 1 in every about 6,000 children every year. And the most important part here being that there is an absence of ganglia or nerve cells that occurs in the distal colon of the patient. So if you look at this little bubble of our colon, this is the distal part of the colon. So we have an absence here somewhat of these nerve cells or ganglia. And you'll be able to appreciate this in the next slide when I'll speak more about the nerves and the exact reason that these children develop this disease. So let's go on to the nerves. So the nerve plexuses. During normal prenatal development, cells from the neural crest migrate into the large intestine, which is the colon, to form 3 nerve plexuses. These plexuses innervate the intestine. They are the submucosal plexus, which is also called the Meissner plexus, the myenteric plexus, which is also called the Auerbach plexus, and the smaller mucosal plexus. All of these plexuses are finely integrated and involved in all aspects of bowel function, including absorption, secretion, motility, and the blood flow regulation. So if we take a closer look at this little picture on my right, we said we have these 3 plexuses which innervate the intestine or the colon, right? So here we have the submucosal plexus, which is also called the Meissner plexus. And then to my right here, we have the myenteric plexus. And within the innermost layer, which is the mucosal layer of the bowel wall, we have the smaller mucosal plexus. So these 3 plexuses together help with the bowel function, which include the absorption, the secretion, motility, and blood flow regulation of this part of the colon. So if we go back to our first slide again, so we said here the disease is characterized by the absence of ganglia in the distal colon of the patient. So back to this slide, what actually happens in these patients is we have the absence of the myenteric plexus and the smaller mucosal plexus. So the plexus which is found within the mucosa and this plexus here, which is the myenteric plexus, is absent in these patients. So if these nerves are absent, you can imagine all the functions that the nerves are responsible for is not going to be able to be carried out. So again, we have the absorption, secretion, motility, and I want to emphasize here the motility because the motility is very important and is one of the biggest reasons why we have the symptoms that we have in Hirschsprung's disease. So let's go further. So, the mechanism of the disease. In patients with Hirschsprung disease, both myenteric and submucosal plexuses are absent in portions of the bowel. The segment lacking neurons are called aganglionic segments, will suffer the lack of peristalsis and also become constricted. So, above we have a picture of our normal bowel. So, children unaffected with Hirschsprung's disease are born with a bowel that looks like this. But in patients who suffer from Hirschsprung's disease, this is the area here. This little narrow constricted part is actually where we have the absence of these myenteric and submucosal plexuses. So because we have the absence of these nerves here, what actually happens is this part narrows down, it's unable to undergo any sort of peristalsis, it's unable to contract, and it becomes constricted. So the proximal non-affected segment of the bowel will struggle to push the content and will ultimately cause this portion to become distended with feces. So if you look at this little sort of bubble above. So this is the actual portion that is affected, or the aganglionic segment, and this is a normal segment. But because this feces that is collected here is unable to pass into this constricted segment, it's going to collect here. So even though this portion of the bowel is not aganglionic, meaning it has a normal set of nerve plexuses, it's unable to push this content because the content is too much and this portion is constricted, so the content cannot go anywhere. So even though this part is close to the aganglionic segment, it is not affected, which means that there is nerve cells here, but it will suffer distension, and this is how these patients have a tendency to develop toxic megacolon. So again, this portion of our bowel is called the descending colon, and the descending colon just holds the feces until it is passed out of the body. So you can imagine this collection of feces and gas that is happening within this distended portion, and it's not very good for the patient because there's all sorts of bacteria and microbiological agents which are found here, and the more they grow and the more they multiply, the worse the prognosis is for our patient. So the particularities of the disease. Hirschsprung's disease is confined to the rectosigmoid region in about 75% of cases. So let's go back. So this is the rectum, and this is the sigmoid, and this is the entire rectosigmoid area. So in 75% of cases of Hirschsprung's disease, this is actually the affected segment, or the aganglionic segment. So this is a segment where those nerves are not found. And you can see here in the picture, it shows quite clearly that this segment is in fact the affected segment because we have this constriction of the rectum and the sigmoid portion of the colon. In 5% of cases, the entire colon is affected. The stomach and the esophagus may also be affected in some cases. Hirschsprung's disease can also present as part of a multi-system disorder, such as in Down syndrome, Bardet-Biedl syndrome, Waardenburg-Shaw syndrome, Mowat-Wilson syndrome, Goldberg-Spritzen megacolon syndrome, cartilage hair hyperplasia, multiple endocrine neoplasia type 2, Smith-Lemli-Opitz syndrome, and congenital central hypoventilation syndrome. So basically, the main point I'm trying to make here is I want you guys to draw a correlation between the development of Hirschsprung's disease in children who suffer from different genetic syndromes. Several genes and specific regions and chromosomes, called loci, have also shown or been suggested to be associated with Hirschsprung's disease. So this is a small table below, and I just put in the common ones. Patients who test positive for the RET gene, the EDNRB gene, the GDNF gene, the EDN3 gene, and these are the chromosomes that they are found on, chromosome 10, 13, 5, and 20. And these are different genes that contribute towards the development of Hirschsprung's disease, and you can see why. So here's a quick description of the functions of these genes and why they lead to the development of Hirschsprung's disease. So the RET gene codes for the proteins that assist cells of the neural crest in their movement through the digestive tract in the development of the embryo. So remember in the beginning I said we have these 3 nerve plexuses which actually develop from the neural crest. So if we have a problem within the neural crest, we're going to have a problem with the development of those different plexuses, and this is how the RET gene contributes to the development of Hirschsprung's. The EDNRB gene codes for proteins that connect the nerve cells to the digestive tract. So again, if we have a problem here, we're going to have the disease present. The GDNF gene is also a protein that potentially promotes the survival of many types of neurons. And finally, we have the EDN3 gene, which is essential for the development of neural crest-derived cell lineages and enteric neurons. So as you can see, all these genes are required in one way or another for the proper development and function of those 3 nerve plexuses. So now let's talk about some signs and symptoms of Hirschsprung's disease. Typically, Hirschsprung's disease is diagnosed shortly after birth because of the presence of megacolon, or because the baby fails to pass the first stool, which is called the meconium, within 48 hours of delivery. Normally, 90% of babies pass their first meconium within 24 hours and 99% of them within 48 hours. So, if you look at my image below in the middle here, we see a newborn which has not passed stool, and you can see this completely distended abdomen. and that is due to the buildup of fecal matter and essentially the development of megacolon in this baby because he's unable to pass stool. The newborn may also have vomiting, which it could be bile stained or fecal, abdominal distension, constipation, which occurs in all patients because they are unable to pass the stool out, overflow type of diarrhea, or anorexia and poor feeding. Continuing with signs and symptoms, some cases of Hirschsprung's disease are diagnosed later in life into the childhood, but usually before the age of 10. These children may experience fecal retention and constipation. So this is an older child, as you can see, and we still have the same sort of clinical picture. We have a huge distension of the non-affected segment, which is proximal to the affected aganglionic segment, and you can see our child has this distended abdomen. So we have fecal retention and constipation, abdominal distension, expressing a failure to grow, a loss of subcutaneous fat, and child appears malnourished and suffers stunted growth. And there may also be a degree of anemia. So if you look closely at this child, you can see the presence of the ribs, which means there's somewhat a loss of subcutaneous fat, and the child appears malnourished, might be shorter, and you can see a lot of bones can be seen, and the abdomen is distended. So this is a classical picture of an older child with Hirschsprung's. The diagnosis of the disease. So together with the presenting signs and symptoms, a full thickness rectal biopsy is needed. The definitive diagnosis of Hirschsprung's disease is confirmed by a full thickness rectal biopsy demonstrating the absence of ganglion cells. The specimen must be obtained at least 1.5 centimeters above the dentate line because aganglionosis may be able to present below this level. Disadvantages of the full thickness rectal biopsy include the necessity of general anesthesia and risks of bleeding and scarring. So in order to definitively prove the absence of these nerve plexuses within the bowel wall and to confirm that the patient's distended abdomen, constipation, and toxic megacolon is due to the absence of these ganglionic cells within the colon wall, a full thickness rectal biopsy is needed. The rectal biopsy will be able to show, once taken, put on a slide, we are able to look at it under a microscope and confirm the absence of these respective ganglia. So the procedure of the full thickness rectal biopsy is shown above. You can see this biopsy gun, which is inserted into the child's anal canal and well into the affected segment, and a biopsy is taken from that area. We could also do a suctional biopsy. The simple suction rectal biopsy has been used to obtain tissue for the histological examination. Rectal mucosa and submucosa are sucked into the suction device, and a self-contained cylindric blade excises the tissue. The distinct advantage of the suction biopsy is that it can easily be performed at bedside. Diagnostic yield for the full thickness rectal biopsy is significantly better than that of suctional biopsy. And below is just the histological view of the biopsy specimens, which show in picture A, we have the normal ganglionated bowel, which is found in children who are unaffected with Hirschsprung's. In image B, we have a patient who suffers from Hirschsprung's, and we can note the absence of those ganglia in the colon wall. And C is another patient with Hirschsprung's. We just use a different staining technique. Instead of the classic hematoxylin and eosin, the staining procedure was done with acetylcholinesterase. So continuing with other diagnostic procedures, we could also use imaging studies, and a plain abdominal radiograph may show distended bowel loops with paucity of air in the rectum. So if you look at this image to my right above, we have a supine abdominal film which demonstrates numerous dilated loops of bowel, mostly likely down to the descending colon. So we can see these widely distended loops of bowel and a lot of gas which is seen in the pelvis. So keep in mind that even though these patients are not able to pass stool or feces, they are also unable to pass gas. So this is also an important thing to keep in mind because a lot of times we are able to see the gas on an x-ray. The barium enema, for which classic findings of Hirschsprung's disease, is a narrow distal colon with proximal dilation. However, findings are difficult to interpret in neonates meaning children under the age of 1 month, and do not demonstrate this transition zone in approximately 25% of the time. Retention of rectal contrast for longer than 24 hours after the barium enema also suggests a diagnosis of Hirschsprung's disease. So on my picture on the right below, we have the barium enema, which shows a patient with Hirschsprung's disease. As we can note here, we see this distended loop of bowel. So we have that toxic megacolon developing, and we can see here this constricting tapering end, which was classic for the rectosigmoid area, which is the most commonly affected. And another test we could use is the anorectal manometry, which detects the relaxation reflex of the internal sphincter after distension of the rectal lumen. This normal inhibitory reflex is presumed absent in patients with Hirschsprung's disease. So now let's talk about some treatment options in Hirschsprung's disease. So essentially, all patients with Hirschsprung's need to be operated and the aganglionic segment has to be removed. But of course, we have to be able to treat the child before the surgical intervention is performed. And this is where the preoperative treatment comes in. So the nursing maneuver is a common preoperative treatment option in Hirschsprung's disease. And here, a well-lubricated catheter is passed into the anus past the rectosigmoid area, because again, the rectosigmoid area is most affected. So we want to go past that affected segment so we reach into the part where the feces is actually collecting, which is in the normal segment. So we have to push the catheter in past the aganglionic segment into the dilated portion of the bowel. So a common question is, how do we know that we are past the aganglionic segment? So when we reach this area, passage of gas and feces will occur through the catheter. So once we pass our catheter through this aganglionic segment, you're definitely going to notice the release of gas, and you will also see the expression of the child's face of somewhat of a relief, because once that gas is eliminated as we push that Foley catheter through, the child is going to be very happy that he was able to pass the gas and he's no longer got these abdominal cramping and pain. So once we reach this area, passage of gas and feces will occur through the catheter, and that's how we know we're in the correct place. Saline solution is then inserted and withdrawn multiple times through this catheter, allowing for feces to be cleared out. So if you look at my image in the bottom, you can see we use the Foley catheter, a syringe, a lubricant, an emesis basin, and saline solution. And basically what we do is we rinse out the area of the bowel, which is collecting all the fecal matter, so that we don't have the development of the toxic megacolon. And this is done many times a day because newborns and infants can pass stool up to 3 to 5 times a day. So the process is repeated multiple times during the day, every day, until the child is fit enough for surgery. So this process is repeated over and over several times until the withdrawn liquid appears almost clear, and that's how we know we were able to remove all that fecal matter from the bowel. So the surgical treatment, the treatment of Hirschsprung's disease consists of surgical removal, which means the resection of the abnormal section of the colon, followed by reanastomosis. Initially, a colostomy or ileostomy is performed to decompress the intestine, divert the fecal stream, and rest the normal bowel. The stoma is placed above the affected bowel segment. Again, we don't want it below, because if it's below, there will be no point of it. We have to have it above the affected segment so that all that fecal matter can drain straight out into the stoma. Definitive surgery is done at an age of 1 year, and here the non-functioning bowel segment is removed with various pull-through procedures, including abdominal perineal, endorectal, or rectorectal pull-throughs. So briefly, just to explain, here we have healthy sections and we have another healthy section here, and in the middle we have this aganglionic segment, or the segment which is affected by Hirschsprung's disease. That segment is resected, and the two normal segments where we have the normal nerve cells present and all those normal functions of the bowel, which means contractions, secretion, blood flow regulation, etc., is reattached. And once this procedure is done, our patient is able to go on leading a healthy, normal life. And that brings us to the end of this lecture on Hirschsprung's disease. Thank you guys so much for watching. Please make sure to like, comment, subscribe, and share. I hope you find these lectures very informative and interesting. If you have any suggestions, you can drop them in a comment below. And if you'd like to download a copy of this presentation, you can click the link in the bio. Take care and bye for now.